Thank you, everyone. So I'd like to introduce Abby. So Ms. Abby Collier is the director at the National Center for Fatality Review and Prevention, and it's a program of the Michigan Public Health Institute. In this role, Ms. Collier leads the National Center in providing technical assistance and support to local and state child death review and fetal infant mortality review teams throughout the United States. One of her focus areas is building collaboration between CDR and FEMA. Ms. Collier provides training on a variety of topics, including improving death scene investigations, best practices for CDR and FEMA reviews, self-care and vicarious trauma, writing prevention recommendations, implementing evidence-based recommendations, advocacy, and engaging partners. We've had the pleasure of working with Ms. Collier for several years now, and I'm very excited for her presentation today. So with no further ado, thank you, Abby, and we look forward to your presentation.
Well, first and foremost, thank you for having me. Working with state and local teams is the best part of our job at the National Center, and so we're always very excited to be here today with you. I will be joined a little bit later by one of my colleagues, Susanna Joy, who will be helping us walk through some mock cases. For some reason, I am not seeing the ability to share my screen.
Sorry, give me just one moment.
All right. So hopefully you can see my slides.
We can, thank you.
All right. So we're going to cover some pretty broad ground today in talking about how child death review teams can use system lenses to understand the risk and protective factors surrounding how and why kids die. And we'll do that kind of using some framework from brain science, and then we'll talk about how data in the case reporting system can really support your team in making this shift from writing recommendations to embracing findings. So first and foremost, I want to share that although we are so thankful for our partnership with the federal government, the information that I'm going to share today are mine and Susanna's opinions, not the opinion of HHS or the US government. So I hit on this already, but just again, in summary, today we're going to talk about how we move from findings to recommendations and why we made that change. We're going to talk about life stressors, which is a relatively new section in the case reporting system. We're going to quickly hit on some key fundamentals of brain science and the social-ecological model, and then we're going to walk through some mock cases. If you have questions or comments as I'm sharing, please use the chat or unmute yourselves if that's an option. Your voice as folks on the ground doing the reviews is so important to us. And so I look forward to hearing your experience. And I apologize for the barking dog. So why are we shifting from this model of asking teams to write recommendations, to move away from writing recommendations and move towards writing findings? Well, the main reason that we are shifting that model is because we know for child death review teams, it's really challenging to write a well-crafted, evidence-based recommendation on every single case. And sometimes the recommendations that we need to write involve partners who are not around the review table. And so about 18 to 24 months ago, we started this shift of identifying findings. And the goal with that is to focus on the problem. Findings highlight very specific systems gaps and successes. And if you kind of pause to think about the work we do in child death review, that is really the power of multidisciplinary review, is that we put the puzzle together of how our systems respond. And sometimes we see, a great success, and other times we see gaps. Recommendations provide the answers. And those answers are complicated. They're multifaceted, they require a deep dive into data, and they require us to engage a wide variety of partners. And so it's our recommendation at the National Center, you write those recommendations every 12 to 14 months based on the findings you gather during the review process. So we think about the shift to findings as sort of a continuous cycle. The first step is during the case review for the team to create a finding. And I'll walk through what are those specific components of a finding in the upcoming slides. Then the second piece in this process is to identify your findings and review them in aggregate. And I can talk about where that lives in the case reporting system. The third piece is to use those findings and write recommendations. And then the final piece is to move towards prevention. If we're doing this work in a systematic way, we're always working somewhere in this cycle of findings. And I know sometimes it's hard to put our arms around what it means to do prevention work in fatality review. Sometimes it's really nebulous and hard to identify. And so it's important to remember that the review process is part of prevention work, and so is writing those recommendations. So what is a finding? A finding is a concrete fact about a case. It's tied to key risk and protective factors. A little bit later, when we're talking about the key elements of brain science, it's an opportunity for you to think about how you can work those elements into your findings. Findings should focus on how our systems interact and be identified for every case. As I said earlier, we want to use them to drive our formal prevention recommendations, and that they should span a broad set of categories, everything from characteristics of the child and caregivers to social determinants of health and equity. By taking a broad systems look as you're writing your findings, you have the ability to aggregate them across causes of death, across cases, and really see what are some of those underlying risk factors that span multiple causes of death. So what goes into a specific finding? We think of them as having sort of three key components. The first is they identify the system being targeted. To be very clear who you're talking to, whenever possible, include the name of the system. So if you're talking about a specific hospital, a specific law enforcement agency, include that name. And the reason we want you to be specific is because when you aggregate your findings, you might see interesting patterns across agencies, both from a systems gaps perspective, but maybe more importantly, from a systems success perspective. We might see that maybe one law enforcement agency always does a really comprehensive death scene investigation, or maybe we see that certain child welfare regions or jurisdictions always goes above and beyond in meeting some family needs. So be as specific as you can with the agency. The second component of a finding is to identify the policy or program area that you're trying to impact. And again, here you want to be as specific as you can be. I like to give the example of hospitals because I think it really demonstrates how the complex inner workings of an organization can impact our prevention work. Let's say that you're writing a recommendation to your local hospital about infant safe sleep. Where do you send it? It could go to leadership for sure. It could go to labor and delivery. It could go to pediatrics. It could go to OBGYN care. It could go to the emergency department. It could go anywhere. And so it's important to consider what program you're writing the finding about, because again, they're multifaceted. And so if you're writing a finding about infant safe sleep, just to stick with that example, and you want to speak to education given during the prenatal period, say that's where you're targeting your finding. And then the third component of a finding is case-specific rationale. You want to highlight why from that particular case it's important to recognize this finding. Findings are intended to be short, a sentence, maybe two. St. John's Hospital labor and delivery providing, could provide infant safe sleep education to the birthing parent and their partner. That could be an example. Findings are a great way to talk with your team about the things that went well in the case and the things that were a little bit of a challenge. The reason we ask you to capture a finding both on risk factors, so sort of the opportunities for growth, and on successes is because sometimes when we're working on prevention, we focus solely on addressing deficits, and we don't spend a lot of time talking about replicating success. So again, if you have some success happening in your community, which I know you all do, document those as well. It's also important in the fatality review process to remember that sometimes things do go right. Obviously, this is the worst outcome that could happen. A child died. I don't want to minimize that, but there are positive things that happen in how agencies interact with that family before the death, during the death, and after the death, and we should capture those. It's also an opportunity to provide feedback to agencies, particularly about what they're doing well. It's important to note that our findings can be biased by our unconscious bias as individuals, by the experiences that we've had, and sort of the lens we bring into the review meeting. And so equity in findings is really important, not only in how you write your findings, but also how you identify findings from the case. These findings really provide us with a unique opportunity to see how different families navigate systems of care, and hear both from the professionals and sometimes from the family about how that process went. Considering equity in your findings will help you consider equity in your prevention recommendations. We know that that kind of idea of intent versus impact. We typically mean well or have a positive intent when we're writing prevention recommendations or findings, but sometimes even though our intent was positive, the impact can be negative or disproportionate on certain groups. And so it's really important to be mindful and consider equity as you're writing those findings and moving through the recommendation process. We have a number of resources on our website to help support discussion about equity and fatality review, and some of that we'll talk about specific to the brain science model. One of the ways that we are trying to support the identification of issues of equity is by talking about life stressors. We know that the context in which the family lived, the community functions, professionals work is, I think of it as like a piece of fabric. It's a complicated tapestry of threads that come together to create a picture. We also know that we have to kind of look at those threads individually, and we also have to kind of take a step back and look at the whole picture. Life stressors were incorporated into the case reporting system in version 5.1, which launched about 18 months ago, April of 2020, which we recognize was really the beginning of the COVID-19 pandemic. And so lots of folks are not familiar with life stressors. That's okay. Obviously, we had lots of other things going on. But they were added not only to help you capture in a data-driven way what the picture, that context looks like, but also as an opportunity to have a discussion as a team about some topics that can be really challenging. Talking about things like racism or housing instability, discord within a family, transitions for kiddos, can be really difficult. And so we've seen some success for teams already in using the life stressors section as sort of a springboard for that conversation. It's never something that we take lightly at the National Center to make the decision to add to the case reporting system. We know it's a very long form, very comprehensive, and so adding questions, let alone a new section, is always something we approach with caution. We recognize that the life stressors are a little bit challenging for teams to get their arms around. First and foremost, they're subjective. Whether or not someone experienced racism, if you can't ask the person, you're making a subjective interpretation. Same with bullying. What might feel like bullying to one young person might not be bullying to another young person, or even to us. We didn't add these to frustrate you with subjective responses. We added them to capture, again, that sort of broad picture, and to provide your team with that opportunity to talk about it. We know that getting information on life stressors requires teams to look at a wide variety of data sources, everything from your typical child death review records to census information or other surveillance system information. We encourage teams to use a consensus building approach when they're talking about life stressors, and I'll provide some suggestions about what that could look like. The National Center has a couple of written guidances and a training module on how to identify life stressors and how to talk about them. Excuse me. It's always something that we are happy to provide additional training on as well. So how do you use your life stressors data? One is to impact health equities. What we're hearing from communities is that these life stressors data provide them with proof, so to speak, of what they already knew existed in their community. It gives them that documented context of what it is like to live in their community. They should be used to drive prevention. We should be considering these components as we're writing our findings and writing our recommendations. Hopefully, by collecting life stressor data, it adds a new facet to how you can use fatality review data. So maybe you want to look at youth suicides, for example, and maybe you want to look at them and sort by some key relationship stressors. You'll have the ability to do that by collecting data in the life stressors section. We will be adding an additional domain in version 6, but currently there are these 7 domains for life stressors. They're social, economic, relationships, school, technology, trauma, and then other. The section we'll be adding is a medical life stressors section. It will be included in version 6 of the case reporting system, which will go live in April of 2022. Here is a screenshot of what the life stressors section looks like in the case reporting system. It is not meant to cover every single experience a family could have. We created these items by reviewing the literature and identifying sort of what we were seeing as common themes across cases entered in the case reporting system. It's really important to note that for each one of these, you have the ability of selecting none listed below. And I would highly encourage you to use those. It's a way of differentiating between nothing was present for that child and family from cases where this information was skipped for whatever reason. The social economic life stressors appear for all children, and the balance of them appear just for children ages 5 and over. Medical life stressors will appear for all children as well, and will contain things like perceived provider discrimination or inability to access care being unavailable, not understanding a treatment plan, etc. There'll also be some minor expansions to the other ones. As I said, you may need to consult a few other data sources to identify life stressors that a family is experiencing. And so here are some national suggestions. Like I said, census tract data, county health rankings, youth risk behavioral surveillance system data is great to go to, as are other national surveillance systems like PRAMS, the pregnancy risk, PRAMS, I don't remember the acronym, or things like Whisker and Wonders. You probably have some Florida specific data sources you could access as well, and I would just encourage you to take a look at them. We all live our lives in the context of where we live and work, and the families that we might be reviewing their deaths might live and work and play in circumstances that are so very different than what we as individuals experience. It's important, like I said, to come to a consensus building approach when you're thinking about life stressors. And so the way we see this play out is sort of 3 or 4 common ways. The first is for the team to do some voting on the process. We see this happen by people Xeroxing or copying the half page of findings that I showed on the previous slide and distributing it at the beginning of the case, asking team members to sort of tick off the findings as they hear which ones may have applied to the kid. We see that in an electronic form as well, so individuals being able to, go into the SurveyMonkey or whatever and do that same function. We also see consensus through open discussion. This is particularly powerful for communities who maybe have lower numbers of cases, and they can dive in a little bit deeper. And then the final way we have been seeing is to have team leadership identify the findings that they think apply and asking the team to respond to them. There won't probably ever be 100% consensus, and that's okay. A simple majority rules is a fine way to navigate through the findings. I will say it's incredibly important as you're talking about these life stressors to ensure that team members equally have an opportunity to share their feedback on what life stressors may have impacted the child, and that the power across the team is distributed in a way that everybody's voice is heard. And so for many communities, that's kind of voting or taking them off individually and compiling those results. I see a question in the chat. A couple comments. So another data source to consider for life stressors, especially for the social economic ones, are United Way's ALICE system, which is Asset Limited Income Constrained Employment Research. And so that's something Florida specific to consider. And thank you to whomever tossed that into the chat. All right, I'm gonna read this next question, which is focusing on life stressors is important. How do they connect to ACEs and other research around those topics? That is such a good question. We have taken a look. I just was kind of scroll ahead a little in my slides. We've taken a crosswalk of life stressors and data in the case reporting system to the existing ACEs. I think it's later in my slides where I show that that crosswalk and talk about how you can use fatality review to help understand ACEs that kiddos may face in your community. So if I don't come back to this and answer your question in a way that makes sense, I will check in after we get to that ACEs portion. We know that the case reporting system is comprehensive and there's a lot of data to be collected. We want the case reporting system to support your prevention work, and we want it to capture all of the amazing work that you're doing. In her introduction, Connie gave a couple of examples that were so powerful of how child death review has impacted the lives of kids in Florida. And so we want to capture that. And so there's a number of ways that the case reporting system is set up to help support that. I'm going to talk through sort of 4 components of it. The first is how to document findings. The second is how to utilize a standardized report. The third is around writing recommendations. And the fourth is about documenting those recommendations. So I've talked about this already, how to write findings. When you write those findings in that first part of your case review, you can document those in Section L. Section L was modified in version 5.1 to ask just 4 questions. It used to have about 11. It asks you to document the positive. It asks you to document the systems gap. And then it asks you to document any recommendations if the team identifies them. The second part of this is we've built in a standardized report number 30, that identifies your findings. So it pulls your findings from cases and aggregates them for you. It allows you to see them all in one place and gives you the opportunity to sort by things like cause and manner or the findings themselves. This standardized report is meant to be the jumping off place for identifying what buckets you might want to group your findings into. So let's say you're looking at water safety, you can look at all of your drowning deaths and see what were those findings across those. Or maybe you're interested in findings for toddler preschool age children ages 1 to 4. Again, you can kind of group them that way. The third piece of this process is to convene your partners and write recommendations. I know I'm kind of breezing through this process like it's so easy. You just write your findings and you document them and write your recommendations and then you do the work. Please know that I recognize this is the hardest part of fatality review and that it's never a linear process and that it can be quite challenging. So I'm saying it in a lighthearted way with a smile on my face, but please don't think I discount the work that goes into that. Once you've convened your partners and written your recommendations, there's an opportunity to document aggregate recommendations in the case reporting system to really keep track of the work that your team is doing. These changes that went into the case reporting system in version 5.1 were identified through a series of focus groups. We held about 6 focus groups 2 years ago and really heard from state and local teams around what would be helpful for them. We hope this process gives you a loose outline or framework to use when you're working through prevention. I'm gonna move us forward a little bit to talk about using lessons from brain science in fatality review, but before I do that, I see there's a question. Are life stressors answered for the child or is it the family environment? So that's a great question. We give the guidance in the data dictionary to answer them about the family or the immediate system in which the child lived. So typically we would see that as caregivers, siblings, etc. Again, I know that's a little bit subjective, but for one family, the relationship to the community could be really significant. For another family, it might not be. So we didn't want to limit it to just the child and or their immediate caregivers. We wanted to leave it a little bit nebulous so that as a team, you could identify what may have impacted the death. That's a great question. Thank you. So moving on to talking about lessons learned from brain science. We partnered with some of our colleagues in the child welfare arena to really pull on some key terms and concepts from brain science to see how we could use them in fatality review. In general, we're supporting a move from looking at individual behaviors to looking at systems. And so that transition in a very practical sense sounds like moving away from why didn't the family to why couldn't the family. This sort of minor change looks at how the systems that families navigate their way through, the community that they live in, their individual circumstances, all interact to create the situation that happened to that child. And so moving away from conversations about individual behavior and blaming individuals really allows us to take a step back and look at how systems may or may not work. This guidance is available on our website. We also have a fillable PDF of a prevention matrix that we have in Word that you can use as a team if you find that to be helpful for you. It's important to note that in general, child death review is grounded in the social-ecological model. It's grounded in this model because it looks at the sort of layered relationships between individual behavior, close relationships, the community, and society as a whole. This social ecological model is what we used in the brain science guidance, and it's an important way to consider prevention. When we think about prevention, we tend to default to the idea of individual education. So we think about, again, I'll stick with infant safe sleep. We do a lot around engaging individual people, right? Educating them on safe sleep. But if we could educate our way out of a problem, we wouldn't have sleep-related deaths anymore. So the social ecological model gives us those sort of predefined layers for us to think about prevention work. So I'm going to dive in pretty briefly into each one of those layers. Individual layer is that sort of first or smallest layer. It identifies individual risk and protective factors. It's typically experiences, behavior, things like genetic predispositions. Excuse me. It also looks at things like history of abuse or age. Sometimes this is where we see ACEs play out. It also, again, focuses on education from a prevention standpoint about risk and protective factors, as well as programs that promote positive relationships and interactions. The second level, this lighter blue color, is the relationship level. That examines the close relationships that increase or reduce risk. To tie us back to life stressors, when we're considering life stressors, what we're really thinking about is the individual level and the relationship level. These relationships are often considered the closest social circle for the child. That's peers, family members. If the child is maybe a little bit older, it might be a significant other. If the child's working, it could be a work environment as well. Prevention strategies in this section of the social ecological model also focus on some education, but they include things like mentoring, family or group-based education. So some of what we see here could be shifting of social norms. So if we talk about infant safe sleep in relationship circles, we might be able to start to leverage change across maybe generations of a family or across other groups that we've talked about. Other prevention strategies that fall in this sphere are things that promote resilience, and we'll talk about what resilience is in this context. The third level is community, and that really explores the environment in which relationships exist. It could be schools, neighborhoods, again, work environments. Prevention strategies at the community level typically focus on improving the environment, and it's important to note that that's not only the physical environment, it's also the social environment. So we're seeing more and more come out in prevention work about the importance of social marketing, engaging multiple players so that, families may be hearing from their pediatrician or medical providers about infant safe sleep, but that they're also hearing about it in the places that they worship, work, and play. So they hear about it from their clergy, maybe the grandparents are hearing about it at a senior center, that there's this community saturation of information. And then the fourth, I'll pause. Prevention work in the community sphere can look like improved housing programs, school policies directed at reducing bullying, or programs that reduce isolation. The fourth and final sphere of the social ecological model is society. So that really broad, over-encompassing sphere. In this level, we see things that help create or eliminate risk factors. These include social, cultural, religious norms. Prevention strategies at the societal level often focus on policy change. And I mean that policy change with a big P, so legislative policy, but also with a little p, agency policy. Sometimes we undervalue the role of agency policy in prevention work, but it's just as important as legislative policy. We'll talk a little bit later about how to kind of scaffold or overlap some of these strategies to do really important prevention work. So moving on to talk about why brain science, and I've hit on some of this already, so I'm not going to continue to repeat myself, but it is important enough to reiterate that the reason we talk about this model and the reason that we want people to use brain science in the social ecological model is that it provides us with clear framework, common language, key terms around how families live and work. It also provides us with the opportunity to analyze the sort of complex, multifaceted nature of community. It's about, individuals, family relationships, the neighborhood or community that they live in, and our society as a whole. The social ecological model, again, just provides us with that framework to have discussion. Sometimes in prevention work, one of the biggest challenges is deciding on common language. And so hopefully both brain science and the social ecological model give your team just a little bit of structure. I know that sometimes the power and fatality review is the organic nature in which we discuss cases and identify how sort of things unfolded, and we never want to stifle that. So this is really kind of meant to be a loose outline or a loose structure that helps you reach your goals. And it's important to note that both of these frameworks focus on the broad community and system as a whole. As I said, we are really supporting the move away from really evaluating a lot of individual risk or individual behavior. I'm going to jump in now to talk about some key terms related to brain science. So the first term I want to talk about is brain architecture. Brain architecture is sort of defined as the early experiences, the foundation for learning, behavior, and health. As many of us may know, the brain first develops essential skills and neural connections, and then once those sort of basic or essential skills are developed, the brain begins to develop more advanced and complicated skills. One of the key skills that develops during early childhood is the idea of serve and return. So what this is when we observe a child offering an emotional response like crying, smiling, babbling, and the caregiver responds in an appropriate way, the child's brain begins to make those important connections. If that response is missing or inconsistent, brain development gets disrupted, and it can result in physical, mental, and emotional impairments that impact all aspects of the child's life. It's important to note that although brain architecture forms in the early years, and it's sort of most active at a young age, they can be formed throughout life. We have some great resources that explore brain architecture, and there's actually a really interesting brain architecture game that you can play as a team that looks at how experience shapes the brain. And so for hands-on learners like myself, you get the opportunity to kind of build a brain, attach some weights to it, and see where your brain is successful and maybe where your brain is not successful. The next key concept I'm going to talk about is stress response. We're all familiar with stress. It's really a normal part of life. We think about stress typically as a really negative response, but it is important to note that there are 3 types of stress. The first is positive stress, and that's exactly what it sounds like, right? That's something that in the long term is a protective factor or important for the child to experience. Positive stress moments might be the first day of school, meeting new people, the moments before an athletic event starts. Tolerable stress is the second type of stress, and this is that stress that happens when things like a death of a family member, a natural disaster, divorce, regressive behaviors, etc. Tolerable stress is tolerable typically because the child has support in place from key caregivers to mitigate that tolerable stress. Tolerable stress tends to be time limited and specific. The third type of stress is toxic stress. This is a result of abuse, neglect, substance use, or mental health issues in a caregiver, economic insecurity, racism, poverty, etc. We all need to learn to respond to stress. It's an important part of our development. Not all stress is harmful. Again, we have that sort of positive stress category. However, if a child's stress response is activated for a long time, their brain architecture can be impacted, resulting in lifelong challenges. But I want to point out the opposite is true as well. So if a child has that positive supportive relationship with adults and caregivers, and it can be one adult, one caregiver, it can greatly reduce the negative impacts of stress. The next piece I want to talk about are ACEs, and then maybe their lesser known companion of positive childhood experiences. We're all probably familiar with the landmark ACEs study released in the late 90s by Kaiser Permanente, which looked at the relationship between experience and physical and mental health. They studied it across adults from 25 states, and found some very important health outcomes. Adults who had experienced 4 or more ACEs were at a greater risk for negative outcomes across behavioral, physical, and mental health. Certain populations, women, racial and ethnic minorities, were at a greater risk of experiencing ACEs. ACEs fall in sort of, or I guess are often grouped into 3 categories. The first is abuse, which we think of as physical, emotional, or sexual abuse. The second is neglect, again, physical or emotional. And then the third, which is maybe a little harder to get our arms around, is considered household dysfunction. Things like mental illness, incarcerated caregivers, if a parent was treated violently or a caregiver was treated violently, especially a female identified mother, substance abuse, and divorce. In the case reporting system, as I said earlier, we do have proxy variables for ACEs, and I'll talk about how you can look at those shortly. It's important to also consider the relationship between individual experiences that we think of as ACEs and the community in which the child lives. So the Building Community Resilience Initiative created an ACEs tree that really illustrates the relationship between adversity within a family and adversity within a community. And adverse communities who have challenges like lack of affordable and safe housing, lack of childcare, violence, discrimination, sort of have this compounding effect with individual ACEs. So individuals more likely to experience individual ACEs may be more likely to live in a community who have a more adverse environment. And so it just sort of can pile on in some communities. So it's important to consider that. If you have the opportunity to visit our guidance, we have a great graphic of this that, again, I'm a visual learner, really pulls together some of these concepts. Positive childhood experiences are, again, something that we don't talk as much about, and it's not as well documented in the literature. Positive childhood experiences are the opportunities for the child to feel safe, heard, and connected to their family and community. And again, it's important to point out that this can be one person, that one caring adult, that coach, that pastor, that parent, that older babysitter, whomever. In the research done on positive childhood experiences, there are 7 key questions that are asked to identify positive childhood experiences. And they include things like, did the child feel that they were able to talk to their family? Did they feel like they were understood? Did they feel like they were able to participate in community traditions, feel a sense of belonging and supported by friends? Did the child feel safe and protected at home? As I said, positive childhood experiences aren't as well documented in the literature, but where they are documented, they're found to directly mitigate the impact of ACEs. So as we're thinking about life stressors and findings, we're obviously going to talk about ACEs and sort of the negative experiences that someone has. But let's also consider what would happen if we talked about positive experiences that someone may have. The next piece I'm going to hit on is called hope science. This was a new concept to me as we started exploring this work together. And I have to admit, I find it fascinating. Oops, sorry about that. Hope science is the ability to demonstrate that hope serves as a buffer against adverse life events. So the idea that hope is not simply an emotion, but a theory with sound validated measures for adults and children. There's thousands of studies published that all demonstrate hope is the single best predictor of well-being compared to other trauma recovery measures. The principles of hope science are that there are two fundamental processes: pathways and agencies. Pathways are the mental strategies or roadmaps that people use to achieve their desired goals. So pathways are things like, I'm going to do X to get to Y. The second component of agency is about willpower or mental energy needed to sustain and reach those goals. Hopeful children have the willpower to reach their goals. They persevere through challenges, and they do this by self-regulating their thoughts, behaviors, and emotions. And so it's important to note that for children, these pathways have small measurable benchmarks. So we think about it as like learning a skill. First, they learn how to problem solve something, then they learn a different way to problem solve it, and then they learn how to achieve success. Children who don't have that positive experience of, scaffolding hope tend to be more negative. They experience deficits both in figuring out how to develop pathways, but also in their agency or willpower, mental energy to achieve their goals. The process of hope can be learned and is directly connected to a child's social relationships and their environment. Children who face stressful events or live in stressful communities, having hope, that sort of belief that they can do it, things are goal-oriented, can really help them persevere through challenging times. The final piece I want to hit on is resilience. This is a word we talk about a lot. We throw it around. I personally like the analogy of the dandelion, where some kids are a dandelion where they thrive no matter what environment they're put in, and other kids are an orchid where they really need this sort of pristine environment to function in. The context of resilience is both the capacity to navigate individual, psychological, social, cultural, and physical challenges. It's also important to note that resilience is the individual and community capacity to negotiate for resources. And so we think of resilience as understanding why, excuse me, we think of resilience as kind of a question. We wonder, why are some children resilient and why are others not? Relationships with at least that one adult can have a major impact in resilience. Relationships build the skills necessary to help overcome challenging experiences. They promote a child's sense of hope. And so when we think about resilience, there's four key factors that we want to think about: a supportive child relationship, a sense of perceived control, opportunities to strengthen regulatory skills, and a connection to cultural traditions. These key frameworks are important in understanding brain science, and they're things that we would like you to consider as you start to talk about cases, and I'll provide you with some discussion questions a little bit later on. Oh, well, here's that pretty tree I talked about, is the pair of aces. It's that relationship, again, between adversity within a family and within a community. And I think what's great about this visual is that it really ties together how interconnected we all are, in that sometimes we want to address a challenge or a behavior, and we think of it as an individual challenge. Poverty is a great example, where we might say, well, they would have finished high school, or if they had a better job, or they spent their money in a wiser way. I'm not sure. We think of that as maybe individualistic, but really poverty is a community experience. And so what we're trying to do is have an individual correct or address a challenge that really needs to be addressed at the community level. And so I think this is important to keep in mind as we talk about prevention work, because sometimes what we're asking individuals to do is to fix bigger picture things. And so the power of fatality review can be in addressing what you see on the screen as sort of roots of experience. Here is that crosswalk that I mentioned of how you can look at child death review data in the context of ACEs. Now, I could go on and on about the differences between child death review and the ACEs study. There are some pretty significant differences. So please don't do a one-for-one comparison, because they're not. The ACEs study was done on adults who were alive, largely middle class and white. We're reviewing the deaths of children, and we're getting the information secondhand, whereas the original study was self-report. All of that sort of caveat being said, you can use data from child death review to look at ACEs and see how they play out in your community. Several teams throughout the US track ACEs for each case, and have some interesting findings as they move through. I think it comes to no surprise to many of us that these ACE experiences that we see play out in child death review data are pretty consistent across cause and manner of death. So sometimes when we dig to the roots of how a child died in a drowning, we also see some commonalities to how a child died in a sleep environment or in a child abuse and neglect situation. I see a question, are the slides going to be available? I am happy to make them available. Josh and his team already have them, so feel free to share as appropriate. I want to talk about two sort of final concepts in brain science, and then I'm going to be done talking, and you guys are going to talk and go through some mock cases. The first is racism, and the second is poverty. So I'll start with racism. We know that children of color are more likely to experience inequities. Social and environmental determinants of health are imperative for reaching one's full potential, and we have to look at the community in which a child lived, and that extended exposure to toxic stress can compound the impact of ACEs. So I think of this typically, it's sort of a piling on effect. We have a child who experiences extended toxic stress because they have ACEs. They live in a community where there's more adversity, which piles on top. So then they have more toxic stress. So then they experience more ACEs. You see how it just sort of stacks up. And so to get through those layers, it's important to consider what goes into that stack. The other piece I want to talk about is poverty. It's important to understand the impact of poverty in brain development. Both cognitive and academic performance have been shown in thousands of studies to be diminished in children living in poverty, and that there can be lifelong negative consequences for kids who live in poverty. I point this out, again, not from an individualistic framework, but to take a step back and look at that whole kind of context and picture in which the child lived and worked. During the death investigation, we can ask some key questions that get at some of these components. I know they're hard to capture. The first can be questions about a medical history, questions of the biological parents and caregivers, a focus on family and social relationships and living environments, and then school and work experiences as appropriate. The school environment is particularly important for children who are a little bit older. In the guidance that I referenced earlier, there's specific questions that we encourage folks to look at. In the review meeting, here are some suggested questions that talk about how to apply the social ecological model and brain science to your discussion. Talk about the child's early experiences. Did they have a healthy relationship? Talk about the caregiver's experiences. Did they have ACEs or toxic stress? Talk about the services available to that community and what are the gaps in those services? There are some expanded questions again in that guidance. I've hit on this already, so I'm not going to talk anymore about building community resilience, and instead I want to talk for just a minute about excuse me, a prevention matrix that could be helpful for you as child death review team members to consider as you work your way through a case. I am a person who loves a good to-do list, Excel spreadsheet, a matrix to follow. So I find this matrix to be incredibly helpful in considering how we work our way through this work. What you see along the left-hand side are the levels of the social ecological model. Across the top, you see some key concepts of brain science, and then here in the remaining boxes, you see prevention strategies. And so I would highly recommend that when you're working your way towards prevention work, that you use something like this matrix to just map out even what you're already doing. You want to work on infants who die from a suffocation with parents who are receiving medication-assisted treatment for opioids, to pull on Connie's example from earlier. Map out what you're doing. Map out how you're covering here. And sometimes what you'll find, or not sometimes, probably oftentimes what you find is your work is dominated either in one sphere of the social ecological model, or you're only targeting one component of brain science. And so this matrix is sometimes just that helpful framework to use to look at what you're doing related to prevention work. It's not intended to be a check the box, get through them all. When you have it fully completed, you've solved the problem. Unfortunately, it doesn't work that way, but it is meant to help you consider all the different sides of a problem that you're looking at. And again, effective prevention requires multiple strategies, and those strategies span the levels of the social ecological model. So to achieve the greatest impact, you'll want to have a wide variety of strategies across a variety of spheres. I am looking at a question in the chat box, which is, can you talk about hope science and disparities? Yeah, great. That's a great question. So we know that children who are minorities are more likely to experience things like racism and poverty and those sort of cultural or societal ACEs. As a result of those pieces, those children may not have access to the same protective factors. So they may not have access to a caregiver who can complete the serve and return function when they're little. They may not have access to a caregiver who can provide support during a tolerable stress or even toxic stress moment. And I want to be clear, when I say they may not have access to a caregiver, I'm not saying that the caregiver can't fulfill the need. I'm saying there's a barrier preventing the caregiver from fulfilling that need. So maybe a caregiver needs to sleep during the day when a young infant is awake because they work third shift. And so that's their ability. They have less opportunity to interact with a child. And so there's some really great research conducted by Snyder, and I'll put the link in the chat a little bit later, who talks more concretely about this connection. But I think it really boils down to children who experience ACEs, community ACEs, and have those increased risk might struggle with having some access to the protective factors that promote hope. All right, I'm just gonna quick scan the chat to see if I missed any more. Oh, I see some great resources coming up in the chat that you all are sharing with each other. I think that is wonderful, and I look forward to looking at them a little bit later. All right, so I'm gonna look at this last question and then we're gonna get you all talking. So the question is, I worry about policy changes often focus on or stop at hope science without addressing disparities. The experience of poverty and racism should be considered an ACE. I agree with you 100% for what it's worth, which is probably not a whole lot. But we have to really dig into those root causes of ACEs to affect change. We have to get to the bottom of those tree roots. There is research out there on what's called urban ACEs that do consider things like poverty, racism, I think housing instability, and a few others as an ACE. And I don't know that I have the citation at my fingertips, but I can send it to Josh and he can share it. So there is some research building on that topic. In a nutshell, connecting all of these concepts is challenging, of course, but it also will really provide you with that opportunity to shift from individual discussion and blame to systems focus. And I love the questions and comments that are coming in because it shows you're already thinking in this way, and that is how we really impact change. So I have spent a long time talking with you about these important and key concepts, but now we want to dive into some mock cases, and we want to put some of what we've developed to work. So I am joined by my colleague Susanna, who's one of our staff at the National Center and joined you a few years ago in person in your training. 2 years ago, 3 years ago, I don't know.
It's a little bit of a blur the last couple.
Time's interesting right now. Susanna is going to capture what we are talking about in a facilitation tool we use called Miro. So I'm going to go through the case and then I'm going to pop the Miro up on the board, or up on the screen, excuse me. What we're asking you to do, so sort of what to be mindful of as I'm walking through this case, is we want you to identify what were the community factors. We also want you to identify what were the opportunities for change and what were the barriers. So this is, again, a mock case, not based on any one case, so we're not sharing confidential information with you. We have a 2-month-old Black male who died in a sleep-related death. His name was John, and he was found sleeping in an adult bed with his biological mother. Excuse me. John's parents also had a 4-year-old sister who'd been staying with his maternal grandmother since the last month of mom's pregnancy with John. On the day John died, he had a quote-unquote normal day and was placed to sleep on his back in a crib in his parents' room. John woke up around 2 a.m. to feed, and he was inconsolable, kind of crying off and on for a few hours. When John's parents woke at 8 a.m., they found him in the adult bed between his mom and the wall. 911 was called and John was taken to the hospital. A little bit more. At the autopsy, there were no significant findings. A doll reenactment was conducted, and they found that what mom shared in the doll reenactment, or what mom did in the doll reenactment, was consistent with what she had shared with law enforcement. She placed John on his back, the blanket, pacifier, and lovey in his crib. She then showed how she brought him to bed to feed, but she couldn't remember putting him back in his crib. John's father didn't wake in the night, so he really had no information for the doll reenactment. Police questioned parents and sisters separately. Again, that information was all consistent. John's sister reported he cried all the time and that her parents were always tired. John's grandmother paid for his sister to go to daycare, and the provider had no concerns about her safety. John was going to attend when an infant slot opened in a month. His mother was employed full-time third shift in a factory and had gone back to work a week after John's birth because she did not have accumulated leave. Dad worked part-time second shift at a grocery store. Both parents had minor criminal charges for possession of marijuana, theft, and had difficulty getting approved for a lease. Police records did note that the family lived in a cluttered basement apartment, and there was evidence of alcohol use and marijuana in the home. From a public health perspective, we know that John was covered by Medicaid. His parents were not involved with public health services, although they may have qualified for WIC and other benefits based on income. There's some child welfare history with this family. As a child, John's mom had been in foster care for a few days for an unknown reason. Additionally, his maternal grandmother had several reports of neglect and failure to protect John's mother as a child. It appears as though she moved around frequently, making it difficult to locate the family. John's parents had never been substantiated for abuse or neglect. However, there was a report from the pediatrician on John's older sister when she was 4 months old. Case wasn't substantiated and the parents declined supportive services. After John's death, his sister was taken for a forensic evaluation and interview, and there were no concerning findings. John had been seen by his primary care provider for a 2-month checkup about 2 weeks before his death. There were no concerns about development, but based on mom's story, the doctor suspected he may have had colic. This primary care provider was new to the family, as they had just moved to the area 3 months prior. So important to note, a different provider than the one who had made a call about concerns. So that is what we know about the case. Susanna, I am going to turn it over to you.
Susanna, you're muted.
It's once a day. Somebody has to be the one who's muted, and it was me. So
Thank you.
none of you will be. Abby, I'm going to pose these questions and answer them. And if you could just share with me what the folks share, if it's in the chat, that would be fantastic. Oops. So when we're thinking about the case, when we're thinking about John and his death and the time leading up to it, what community or systems level factors do we think may have increased risk? So based on sort of these record summaries that were shared with us in the mock case summary, thinking not so much about John's mother bringing him into her bed and forgetting that he's there and then waking up and he has deceased, but what sort of things around the family, what systems level factors might have increased risk? And when we think about this question, often we encourage teams to ask themselves this: what factors were outside of the control of the family? Because a lot of times that's what sits at the systems level. And so those are the things that we sort of want to think about today. What community or systems level factors may have increased risk in this case?
So folks will use the chat.
Oh, yes, sorry.
So we see social economic factors.
Absolutely.
Mom had to go back to work immediately and didn't have family leave. Keep them coming.
Very good.
Parental fatigue.
Yes, absolutely. I'm so glad that you mentioned that. I think that so often we don't think about the exhaustion that parents are facing. Certainly in this case, we're talking about third shift work and things of that nature. But I think it's hard to meet a parent of a new infant who isn't dealing with severe fatigue. So that's a really good one to point out, I think.
A date, so we got 3 more coming in and then maybe we'll move on. A daycare slot not available.
Great.
Barrier to housing. And lack of medical care. These are all really great.
Perfect. Great. So those are great suggestions, everyone. Those are great observations. So when we're thinking about these factors, what could community system, how could community systems have intervened in these situations? So these have maybe more to do with policy, with resources, with supports. How could the community systems have intervened? And when we're really thinking about is how could they have intervened with these risk factors that we just identified? These socioeconomic factors, the lack of childcare, the lack of stable housing, the parental fatigue. How could our systems have intervened in this case? I'll let you think about it for a second. We'll look in the chat again.
Now it was my turn to talk while muted. I'm just capturing some additional ones from the first question that are up.
Oh, fantastic. There. That's great. There are so many.
Yeah, you guys are doing a great job. So 2 have come in for this second question, Susanna. Subsidized daycare with more slots that may have allowed mom to work an easier shift. And then access to daycare in general.
Fantastic.
This is a great one. Case management services for the family to kind of help them navigate life with the new baby.
Ooh.
Another great one, combine programs within primary care to assist the family with resources. It's called Healthy Steps. And then universal paid parental leave.
I love where your minds are going.
I know, me too. I could stay all day. They don't want us to, but we could. And then why don't we move on to the next one?
Great. That's fantastic. So our final question is this. Thinking about all of these things, what issues related to equity do you think exist in this case or need to be considered for prevention planning? And this is so important. I think that anytime we think about recommendations at the National Center, one of the sort of low-hanging fruit that we try to suggest to folks when it comes to sort of a basic check for equity in our recommendations is, would any of these recommendations impact one community more intensely than another, or would it have any unintended consequences? So we just encourage folks to think about that. Sometimes the recommendations we come up with that question or without it look a little bit different. And so what equity issues do you think might exist in this case, or that we really need to focus on if we're thinking about prevention recommendations? These have been great. Such great suggestions. It makes me miss being in person because I can just hear your enthusiasm and your commitment in these ideas. Stable housing assistance. I'm wondering if this came in on this equity question. I think it is a question of equity.
Yeah.
So I'm going to plop it over here.
Well, I just clicked on that one. Sorry. There you go.
Did you? That's okay. Anything else?
Health inequities, lack of access to care. social economic issues, no access to FMLA.
Absolutely.
Race, lack of resources, drug use. Ooh, this is a really great one. Possible over-policing related to the marijuana charge. And not that there's right or wrong in these, but I think I am reading Susanna's mind from thousands of miles away, but what is great about the suggestions you're giving is how broadly you're looking at this and really focusing on that whole tapestry of how the pieces come together. We will continue to capture these in the chat. We'll finish this Miro board. We're almost out of time, so I want to be respectful of that. We'll plop the rest of these up there, and we'll make sure that the state staff have access to it so that they're able to share it as they think appropriate. You guys just knocked it out of the park with coming up with these questions. We'll end with this piece. If we think about this case from an individual lens, we see things like maybe she should have let the baby cry it out, then she wouldn't be tired. Or how could she fall asleep with her baby in her bed? She had education, we knew it was dangerous. When we approach cases like this, what we see from a systems lens is literally everything you guys already provided as examples, but housing instability, family exhaustion, being overwhelmed, and then all the ways you identified that the system could have intervened. I'm going to slide through this second mock case, but certainly it's available to your state staff and to us, to any of you, if mock cases are helpful. I want to thank you for the opportunity to present today. This is absolutely the best part of our work. We love working with state and local teams. You guys do amazing work. We couldn't do our work without you. So please know that your efforts are seen by all of us at the National Center, and I'm happy to answer any other questions or provide any other resources.
Well, I just want to thank you so much, Abby and Susanna. It's definitely been a pleasure. We learned a lot, and it was a great presentation. For those of you who registered for this summit and provided your mailing address, we have sent out summit packets. I'm not 100% sure if all of them made it in in time, but I'm hopeful that they did. But so these presentations are all captured in the summit packets that have been mailed out to you. So, please feel free to go through that mock case with your team, the one that we weren't able to get to, and also the one that we did. They're great examples, and really get your mind jogging and on the the data to action piece and going from findings and to recommendations. So, thank you for your participation in this exercise. You guys definitely made this interactive as can be without hearing you or seeing you. So we really do appreciate it. Susanna and Abby, please know that all of the posts were not Ken McCain. they were Ken does not have that many great suggestions for this activity. We were copying and pasting, trying to manage the question feature here. So thank you all, and I think we're going to take a 10-minute break and reconvene around 11:20.